Okay.
Would have been the smart thing to do, I guess.
So, neuroanatomy of concussion. So, I did this presentation for healthcare practitioners. So, ask questions as we go. Doesn't need to be formal. Concussion is really complicated, and like a lot of things, it manifests in people differently. So, we never know. I mean, one person's concussion or even subconcussive issues can be completely different from somebody else's. And of course, my clicker's not working.
You turned it off. Did you turn it back on?
Okay, there we go. Okay, this is of course my marketing spiel. So one thing with concussion is it's usually treatment resistant to drugs. There's some people get some relief, and I always show people this in my presentations, the effect of medications. And so the blue human underneath each drug is the percent of people that the drug worked for, and these are the top 10 prescribed meds in the States as of 2016. So the best drugs are working at about a 25% rate, which isn't great. And for concussion, it's even lower. So concussion happens when you catch frisbee with your face.
Oh,
I used to play football, so I had a ton of concussions, and I know that it was a precipitating factor in some of my health issues. So that was us winning provincials in grade 12. And then we all know the effects that concussion can have. So there's a few different scales here. So one that's not talked about is the subconcussive. Okay, and this just means that it's not a high enough degree to be a concussion. So you stand up too quick and hit your head off the bottom of your cupboard, right? And you kind of maybe see stars a little bit. Maybe you have to sit down. You go to the doctor. He's not going to diagnose you with concussion because it wasn't serious enough, right? So multiple subconcussive blows can lead to ongoing neural inflammation. And there's a bunch of downstream effects that happen that allow that to stay on that I'll talk about a little later on. But that's one that we don't talk about. Boxers, fighters, football players, a lot of them, they're not being diagnosed with concussions, but they're getting severe brain issues down the road. And then we have the actual concussive scale and the Glasgow Coma scale, which you'll see utilized in hospitals. And the diagnosis is all based on symptoms, right? Unless you have a hemorrhage in your brain, they're not going to see it in a CT or an MRI. They're not going to see that kind of stuff. So they just go, well, get hit to the head and you have a bunch of these symptoms. You have a concussion, go lay down, don't look at screens, lessen rest, lower your stress, that sort of thing. And then we have post-concussive. And these are symptoms that last longer than 3 months. Okay, so if any of these symptoms or any anxiety, depression, gut issues, anything like that continues, it's considered post-concussive. Mostly you're looking at medications to try to manage symptoms, and that's about all that conventional medicine can offer.
Okay.
And then there's type 4, cumulative. Okay, these can occur decades after a head injury. So you can get a head injury, get initial symptoms, and then they go away. And then years to decades later, you can all of a sudden start developing issues because of something called downstream effects. Okay, and so these are effects that the head injury itself triggers, and then that continues to cascade if it overloads our stress tank, and our body can't hold that. So the number one is gut dysfunctions, which leads to immune dysfunction. And so you can get activation of old infections. You can get toxicity that was there that wasn't a problem that all of a sudden becomes a problem. Eric Budgerson had mold toxicity. It wasn't affecting him until he got enough head injuries. And then all of a sudden his innate immune system, which is like the flamethrower of the immune system, just fired right up and it didn't shut off. Okay. The other thing is emotional limbic. So you'll see trauma in some people. Eric is another one. He has like whole bunch of theta in his frontal lobe. Donna Reed is another one. Is that bothering you? So though that of course is a neurofeedback approach and sometimes a trauma therapy approach to work with that. And again, you don't know who's going to show this and who's not. Some people, it's the intrinsic memory of early trauma. The head injury that happens and the loss of function that occurs is triggering trauma events. So that's another big one. Metabolic issues, our mitochondria start dysfunctioning. And when mitochondria dysfunction, we can't build energy well. And so this is where some people will do well with a ketogenic diet, for instance, because they're not utilizing their glucose well. And the more sugars they take, the more they inflame themselves, and the more we call it excitotoxicity. So the brain starts releasing a bunch of neurotransmitters that cause toxicity, and that will worsen that because free glucose that's not being utilized can cause more inflammation. Hormone issues. This is really, really, really common, especially if it's a neck injury. So if you've had any whiplash of any sort, and obviously we don't think about this, but the head's attached to the neck. So if you get a head injury, you're probably going to get a neck injury as well. And so the hormone issues happen if there's been issues with the pituitary hypothalamus functioning. The best way to pick it up is to look at sex hormones, and if they're a little bit out, you usually can relate that back up to issues in the brain. And for some people, they actually need to be on hormone replacement for life because it's similar to taking birth control for too long. Some women's hormones can never actually bounce back from it, and they need to be on hormonal support long term. And that's just kind of the reality if you get damaged. And we talked a little bit about this too, like with surgery around the pituitary, right? If you happen to get some damage, as of right now, we don't have anything to like rebuild the neuronal model. So we kind of just depend on getting everything balanced as best we can. And we have tools we can actually do that, which is really nice because we don't have to treat a condition. We can just treat the person, right? So the communication issues, you'll see this in a brain map, and I'll show one in a second, but you guys see this all the time with the delta hypocoherence and the bleed, right? And that's usually white matter abnormalities. So you get this shearing, and again, I'll show you guys in a little bit what that looks like. And then cervical alignment issues, and this is where we work with like Dr. Jeff in Kelowna, upper cervical chiros, like Brett Jones, and then Dr. Hillard in Calgary to work, because if you have alignment issues, you don't get good cerebrospinal fluid flow, which can lead to headaches, tinnitus, dizziness, nausea, visual issues, all sorts of things. And for some people, if it happens to hit an area called the insula, area 13 in the brain, kind of if we go like an inch or two in right at the front of the ears, you can also get extreme emotional issues too. Anxiety, addictions, emotional regulation issues. And then vision issues, and this is one, we tend to see a little bit less of this. I think for whatever reason, a lot of people I think end up going other directions and they find vision therapy. But a lot of times, especially if it's a front to back, you have to get the occipital lobe retrained to bring in visual information properly, because usually the misfiring of the optic nerves causes you to feel off balance, dizzy. You can even actually get low blood pressure from it as well. So these are all just different terms. Some of these I've actually coined. They're not published by any means. But persistent cytokine syndrome is the constant release of inflammatory compounds from the immune system. So it starts feeling like it's under attack and it doesn't shut itself off. And so that's where we need to go clean up issues like in the gut, work on the vagal nerve to fix that. So that's just some of those. When we get head injuries, so these potential sources of stress, if this bucket fills itself up and overflows, that's when we get the triggering of the sympathetic system. That will shift our sex hormones and increase our cortisol. And then that causes energy production issues of not utilizing glucose, blood sugar is going up and not being utilized, causes inflammation, causes kidney damage even. And then you get bone loss, salt and water retention issues, weight gain, and then immune system issues where, again, the smart division of the immune system goes low and the division of the immune system we don't want to go high, like inflammatory parts of it go too high. So what these do, whiplash, head injury, traumas, and that sort of thing, is they shrink our stress tank. And so in some cases, they shrink it to the point where things that weren't an issue before become an issue, and then we have to go in and fix them. And there's a statement that helmets prevent brain injury, and we know that that's not true. because until we can get a little specialized helmet under the scalp, it's never going to be able to cushion the balancing of the brain and the head and the coup counter coup forces. So if you can imagine you're driving in a car and you take a sharp turn left, what does your body want to do? It wants to keep heading to the right, right? When you get a hit, the brain immediately, because the skull gets pushed one way, the brain bounces against the skull. And then it actually deflects because the gray matter is so elastic, and it hits the opposite side as well. And that's the counter coup. So you actually get two sides hitting, and that's where you'll see, if you look in the delta brains, like people always get so surprised because I look at their brain map and I say, yeah, it looks like you've had a head injury from this direction to this direction. What happened? And they're like, well, I had a T-bone accident where somebody T-boned me on the back end. And it's like, well, that makes perfect sense with the direction and that. So you'll see that in the delta and the theta range as well.
Magic.
Yeah.
Yeah.
That's what the wizard.
Yeah. So this is on the left something called diffusion tensor imaging. And diffusion tensor imaging looks at the white matter. So these are like the highways of the brain that send communication to all the different regions. After a head injury, you see these arrows, how the shearing of the white matter and then the excitotoxic reaction that happens can actually cause it to break down. And so as far as we know right now, that can't be resolved. So we have to teach the outer part of the brain how to make up for that loss of function. Okay, and that's, you see on the left here, I have those circled. That's a severe head trauma. Yeah, and you can distinguish that from an extreme inflammatory issue, because extreme inflammatory issues will go the opposite. It'll go hypercoherent, which is something called encephalopathy. So, and then I just put this on because depending on where, and again, this is why it's so different for everybody, because depending on what white matter tracts are affected, which completely depends on the angle and the severity of the head injury, you can get all sorts of things affected. So if it happens to be a front to back, you can get issues with decision-making, planning, organization, and motivation, the sense of self, the integrating of the senses, dizziness, all that. You can even get pain if this part ends up, it can get a top-down. Oh, sorry. You get a top-down reaction. So I just show that to say, like, it can be so variable, which is why it's difficult for conventional medicine to treat, because they can only look at the symptoms. I'm going to move this over. What? Oh, sorry. So Liz is interrupting me and not happy with my posture. So okay, so where are we at here? So
your screen.
So the concussive injury happens up here, and it's going to cause axonal damage. And so that's just, the axons are essentially the white matter that we were looking at, all the tracks that go through. And then it's also going to trigger inflammation. Microglia are just the immune cells of the brain. Okay, so they kick in, they go in, they're like the garbage truck. They're going to go in and clean everything up. And then cellular damage can happen. Lipid peroxidation is a fancy term for cell membrane getting damaged. So the outer part that holds the cell together and protects the cell. And then that leads to something called cell death, which we don't want to happen in too great of extent because our cells are already kind of slowly dying. This speeds them up. And then you also get, can you move forward a little bit, ma'am? It's hard for me to see.
How do you see it?
Because I can't see from this angle.
Oh, I see it.
Ow. Pinch me.
Sorry.
You know what? Just go to the end of the table. It's driving me crazy.
Yeah.
Jeez. Okay, so yeah, glutamate release is the big one for this, because glutamate is an excitatory neurotransmitter, so it causes everything to fire up. So you'll usually see beta and high beta going really high in a brain map. This receptor here, called an NMDA receptor, is what's required to be, essentially this glutamate comes and binds, and when it binds, it causes that excitotoxic reaction. One of the main reasons for seizures is actually too much activity going on with that. That'll cause mitochondrial dysfunction, oxidative stress, and you can see the cycle just going in different ways. Initially, we have something called hypermetabolism, so our brain actually starts burning too much glucose, which is bad. We don't want that to happen because then we get more excitotoxicity. And over time, we'll actually get hypometabolism and the glucose utilized drops. And this is type 3 Alzheimer's, and dementia can be caused from this, where the brain isn't using glucose well. And that's the post-head injury type dementias and neurodegeneration that you'll see in like Muhammad Ali. It's a good example. And then because of all this stuff that's happening, you get a susceptibility to repeat injury, because now again, your stress tank shrunk, there's less that your body can handle before it triggers again. And we of course use QEEG as our North Star. So this shows us where to start, right? That's of course a normal brain map. We've looked at about 2,500 different neuroanalyses, and these are the 6 main issues that we always come up with. And so I find it really interesting because whether it's emotional trauma, physical trauma, doing a one on hormones in a few weeks in Kelowna, and it still all holds kind of true, where there's these different underlying effects. So we're of course talking about head injuries specifically. The first subtype, the immune inflammatory subtype, this is where you can get activation of infections, and it's particularly problematic in the gut, because the vagal nerve, which is the nerve that comes down the left brainstem, left side of the neck, all the way down under our diaphragm, and it innervates on all of our organs. It's what controls whether our fight or flight kicks in, whether it shuts our body down, or whether it goes into a calm, rest, and digest state. And so if it gets triggered in certain ways, it can push us too far in one of the directions. And it can cause viral, bacterial, parasitic infections, fungal infections. If there's mold or other toxic issues, they can become a problem because of impaired detox. And detox expression shuts off more. So that's kind of what it looks like in a brain map. You'll see high delta levels. That's a pretty severe one. And then this is how we tell where it's affecting the brain, like I was talking about in the previous brain map. Area 32, area 24, and area 10. If all of those get affected, you're going to see a big issue with emotional issues, depression. Okay, it just happens to be in those areas. If you see it up in areas sometimes 40 through 43, memory and auditory processing issues. So you see people talking like that really bad tinnitus, the ringing in the ears, it can be really bothersome for people, will happen in these auditory regions. This is an example of encephalopathy that was triggered by a head injury. So with this, you guys see this, not quite frequently, but you see it, where all of a sudden it's like you get this earthquake, right, in the brain. That's literally those areas of the brain tripping out. It's like a breaker's blowing, and then the brain flips the breaker back on and things are good. But in that moment, it's like that area of the brain is dark. It's not processing properly. And so you can get all sorts of symptoms from that.
So what's the patient feeling when that happens? Is it noticeable, or is it like just a quick blip?
So his way, yeah. So what he said is he had terrible memory. Someone would tell him something and he would forget. It'd be like they never told him. The other thing that he said he felt like he was dumb. Couldn't integrate. This is happening like every 10 to 30 seconds. So his brain, the area that's required, frontal temporal area that's required to process that and actually allow for learning and integration of memories, was tripping out constantly. So it wasn't processing properly. So yeah, he'd forget things all the time. And he is actually a friend of ours. So we used to joke that he was like a harebrained. Never remember it. He'd make plans and he'd forget he made plans, so he wouldn't show up.
Would never show up.
Yeah. 10-second Tom.
10-second Tom.
10-second Tom.
I wish I could have been there.
Yeah. So,
Jeez.
so yeah, that's and again something that if it is in the case of just the fact that axonal damage, like because a lot of people, the head injury can repair itself and everything normalizes okay. But then this kind of thing starts happening just because of the way that the cells were connected, and then certain ones broke down. It didn't hold the proper pattern, so it started triggering this. And so then we just teach the neurons how to not do that, and you can actually build new pathways to compensate. Add anything you want as we go, by the way, if I'm missing anything. There's a ratio here. Very commonly serotonin issues happen. Because if the immune system overactivates, and this is like microglia in the nervous system, or if it's in the gut, tryptophan that normally makes serotonin and then eventually melatonin is getting shunted over to quinolinic acid, which is neurotoxic. Okay. And again, it's kind of like this way, like the immune system's using a flamethrower to try to clean things up. And now you're not making serotonin. You look at this ratio, you can see it's high, which should be under a 2. I've seen people as high as 80 on this, so they're 40 times too high, and they have almost no serotonin. So they're anxious, they have mood swings, and they can't sleep easily. And so that's where the medications for, like, you'll see trazodone is a very common one. Amitriptyline is another common one, an MAO inhibitor, and a tricyclic. They come in to try to balance that out. But if it's triggered something, you're usually going to get a little bit of an effect at first, and then people are going to start not noticing a good response. Is just a couple articles so that you guys know I'm not lying to you. What happens with the immune response to head injury, and this is all in sync in presentations if you ever want to look at the science. And then inflammatory response being a double-edged sword. We really do need inflammation, but we can't have it going out of control. So call it a double-edged sword. Metabolics. So my cells need mitochondria in order for me to be a powerhouse. These are the little organelles that evolved. They essentially got into an animal cell way long time, billions of years ago, and they allow us to build high amounts of energy so that we can actually have complex cell structure. If it wasn't for mitochondria, we would still be single-celled organisms. But this is what it looks like when you have metabolic imbalances in the brain. And so this is essentially the best way to describe this is the brain's not getting enough energy. Something's causing it to not get enough energy. It could be anemia, it could be thyroid, it could be other hormones, it could be blood flow, it could be cerebral spinal fluid flow. There's all sorts of reasons that energy may not be delivered. Thyroid, there's a lot of factors that affect thyroid, and oftentimes people with head injury will be something we call subclinical hypothyroid. So they're low enough that they're getting symptoms, but they're not low enough where that's getting triggered and flagged by the medical doctor. So they're generally symptomatic. Fatigue, brittle nails, brittle hair, hair falling out. And then again, so you guys know I'm not lying to you, there's just a couple articles. They're good if you're comfortable reading scientific literature. They're good. Even if you just look at the abstracts, you can kind of break it down. So we use an organic acid test. You guys have probably seen a lot of that. I like to order that one because it shows me what's going on with ATP production, the Krebs cycle, how we're producing energy and integrating energy. It also shows me neurotransmitters. I like to do nutritional workup, thyroid, cortisol, if it hasn't already been looked at. Okay. Cortisol, again, this is a funny one. In some people with head injury, you're going to see it go really high, and in other people, you're going to see it drop really low. So completely different approaches, whether it's high or low, but very similar symptoms. So you can get anxiety from having high cortisol, but you can also get it from being too low. Iron lab's really important. The other thing I actually recently learned about iron, EMF exposure. So cell phones, that's another thing that you guys can be talking to people about, just like little tidbits here and there. I don't know if you maybe want to make a note of that on the wonder list. Just like things to remind when talking with clients is people should not be talking on their phone up to their ear. That EMF exposure will actually change the activity on the other side of the brain for sometimes an hour afterwards. And that's just with a 2-minute exposure. Headphones with a mic are a great way, and if not, speakerphone. If you're just at home alone or whatever, and you're not going to be bothering anybody by blasting a speaker, right? So it's really good to just carry a set of headphones around. But what that can do with iron is, I've seen a lot of people lately that are this, and again, I haven't really seen this term coined, but subclinical. So again, below clinical thresholds, doctors are going to pick it up. Subclinical hemochromatosis. So the iron is actually flipping into an oxidized state instead of into a reduced state. So doctors are on ferritin, see if people's iron's low. That tells you if the good iron is low. But a lot of times people are showing low ferritin, but their iron is actually normal. That means that most of it's oxidizing. And so that's, again, kind of one of those things, the rare exceptions where everybody can feel a little bit better by just trying to avoid EMFs, keeping their phone away from them at night, having it on airplane mode. Even if you have plugs in your wall behind your head or like by the bed, so if you have a breaker, which we actually luckily have, it's great. You flip the breaker off so you're not getting exposure to the plug as well. Because we're on alternating current, we can get melatonin disruptions from it. Looking at blue screens before we go to bed, again, people with head injury very commonly need to remove that. And then we also like to get an upper cervical assessment if we see metabolic issues, because if there's blood flow issues to the brain because of an alignment issue, there's nothing we're going to be able to do to fix it. Neurofeedback won't work. They're not getting blood flow, right? Drugs and alcohol worsen that too. And then we have the limbic brain, which we call the child brain. Call mine little Corey. This is what it looks like when the limbic system is hijacking the frontal lobe. So again, depending where this theta rhythm is high, you're going to get different types of symptoms. So for this person, it was mood regulation issues, feeling hopeless, feeling like nothing mattered. The left prefrontal lobe is all about reward. Okay, so you're usually going to get this issue with anxiety, not feeling rewarded by normal things like exercise. People generally feel rewarded after. Amygdala, here this is just a little pathway that shows the different factors that can trigger this amygdala. And again, you guys see this in the Loretta Absolute Power Brain Maps, right, where you can check the hippocampus and the amygdala and then the areas of the cingulate. But there's different things that aggravate the amygdala. Early psychological stress, emotional stress, acute stress, right? So like being stressed at work, for instance, is our fault probably. There's predisposing factors they call genetic. That's honestly very minor. People get pretty stuck on the genetic issues, like, oh, I have methylation issues because of genetics, and I can't break down my stress transmitters well. Usually these are overcome really easily with lifestyle. People who don't break down their stress transmitters can exercise every day and burn them off in that way, rather than having the brain having to kick in to burn them off. And then there's viral, bacterial, and other inflammatory triggers, fungal triggers, that sort of thing. They'll all aggravate the amygdala. And in a brain map, we can see what ones are the worst. And unfortunately, most of our clients have usually 2, 3, or 4 issues going on. When that happens and it's over-triggered, it causes sympathetic arousal, which is fight or flight, causes immune dysfunction, and then inflammation. And that causes symptoms. And then when we feel symptoms, we freak out. Right? We don't like symptoms. We don't like feeling pain. We don't like having brain fog. And then when we freak out, it triggers the amygdala again. So it's this vicious circle going around. Oh, and I don't have it's a vicious circle slide. Damn. Put the note down for me to add that in. Hormones. So there's something, yes, I'm having a discussion and having a presentation. There's something called pregnenolone steal. When the stress response gets stuck on, our pregnenolone, which is our precursor steroid hormone. So steroid hormones are a group of hormones, right? We know quite a bit. We talk a lot about steroids, but there's all these are different. All of our sex hormones are steroid hormones. Cortisol is a steroid hormone. So what ends up happening is this pathway gets redirected down here, and the sex hormones tend to shut off. And head injuries can speed this up, and they can speed it up almost immediately, where you'll see immediate androgen issues, testosterone issues, and this can happen in males or females. And you'll usually see a brain map that looks like this. Oops. I think we could turn it down like one notch. Thanks. And yeah, you'll usually see issues that look like this that don't resolve from neurofeedback or from cognitive behavioral therapy. So yeah, we're in a bad location, eh? So in some cases, these are like the frontal beta and high beta can be a little bit tricky to see in a brain map to know exactly what's going on, because some people are going to actually, if they're control freaks, they'll have this activation, like they need to control their entire reality all the time, or something bad's going to happen, and it can sometimes be as bad as OCD, and sometimes it's not. It's subclinical. If it doesn't respond to neurofeedback, usually in 10, 20 sessions max, you're normally looking at a hormone or a neurotransmitter abnormality that needs to be worked out. And with hormones, again, most of us know the sex hormones, but it's a lot more complex than that. The pituitary gland is spitting out all sorts of stimulating factors. The hypothalamus is releasing all sorts of peptides. They have effects on the entire body. We have the pancreas releasing appetite hormones, insulin, glucagon, enzymes. The pineal with melatonin, thyroid. So there's all of these different glands. Pretty much all of our glands in our body release hormones or peptides, and they all need to be in a symphony. As soon as one goes out of tune, the others have to try to make up for it. So they either drop themselves or increase themselves, and everything is going out of whack. So it is important to go through and balance that out. And this, I always find this interesting. We had a doctor the other day. I sent, I don't remember who it was that I sent a report just requesting some testing. And I requested pregnenolone to be tested because pregnenolone is one of the most important neurosteroids. So it actually helps grow new neurons in the brain, and not just new neurons, but growing new pathways as well. And the doctor didn't even know what it was. So
I don't know what that is.
Pregnenolone?
Yeah, so very common because they don't utilize, it's not part of their training or practice because they're trained to try to diagnose conditions.
Yeah.
And pregnenolone, and the only reason pregnenolone is tested is if children fail to display secondary sexual characteristics. So that's when pregnenolone becomes a test. Other than that, it's not clinically implicated in anything. So unless you're an endocrinologist, you don't even know what it is a lot of the time. You go through biochemistry, and then you go through your 2 years of everything else. You go through your residency, and you forget all the biochemistry. It tends to happen, right? When you're not reviewing something, you forget it. So I like to show this with head injury because I've also had a lot of doctors say head injury doesn't affect hormone. And there's literally 209,000 results on Google Scholar from head injury effect on hormones, and just head injury and hormone in the same search is 224,000. So if anyone says there isn't evidence, then they just have not looked. And because I grew up in the 90s, I use terms like whack hormone symptoms. So these are all I talk about estrogen and testosterone are the most common to talk about. And again, there's a lot of info and a lot of symptoms. So we'll just touch quickly on this. But estrogen being out of balance, there's 3 types of estrogen. Okay, and a really good way to know if your doctor knows hormones is to ask him what the estrogens are. And if they say estradiol and they leave it at that, you know they don't know hormones. Because there's 3. There's estrone, which is E1, estradiol, which is E2, and estriol, which is E3. And if those go out of balance, or the detox of them goes out of balance, you get all these issues. Cervical dysplasia is abnormal cells, and they normally find this in a pap smear. Right? They'll say cervical dysplasia or abnormal cells. That is a precursor to cancer. So it's important to fix that if that's happening. Depression, anxiety, and agitation, uterine cancer, weight gain, water retention, headaches, poor sleep. You guys can read. Panic attacks. This can happen with high or low amounts. So you can't assess it based on symptoms alone. And the unfortunate thing is that's what we do. Doctors will, a lot of times I've seen people on synthetic hormone replacement, sometimes even bioidentical hormones, never been tested. Never. They're just automatically, you're having hot flashes, here's estrogen. When cortisol can cause hot flashes, DHEA can cause hot flashes. You know that.
I know that.
We didn't know that, right?
And
That's
we
why
didn't
we had
know
to
it.
look.
Yeah.
Yeah, so swollen breast, hypothyroid. So these can even make your thyroid look like they're out of whack, right? And that's the symphony again.
Mm-hmm.
So good hormone function. It's required for blood flow to the brain. It increases glucose and oxygen availability, so your brain will actually start utilizing glucose. It's neuroprotective, which we talk a lot about with brain injury, is compounds that are neuroprotective. It increases acetylcholines. It's really important for memory. That's why a lot of menopausal women will start having memory issues. It keeps the blood-brain barrier intact. I wasn't looking at you guys.
We're looking at each other.
We're looking at
have
each other.
notebooks.
This one's really important. Decreases neuronal generation of beta amyloid. Beta amyloid is what causes Alzheimer's. So it can help decrease the amount of amyloid that's generated. Beta amyloid is the bad one. There's alpha amyloid, that's actually good amyloid. antioxidant, long-term memory. LTM is fancy acronym for long-term memory. And it turns on progesterone receptors, and that's another hormone. I'm not going to talk about it because, again, I'm going to have the hormone talk. I'm going to record that. I'll tell you, you can look at that then. But progesterone receptors are required for progesterone to work. So you could have all the progesterone in the world floating around, but if your receptors aren't being expressed, it's not going to work. So estrogen is required for progesterone to work. So if estrogen's out of whack, you need to fix it before you fix progesterone. A lot of women, especially with young women, they have the progesterone. They jump to the progesterone right away. And if there's estrogen issues, they're usually not going to get improvement. Testosterone whack symptoms, and again, this isn't just for men, not just for shampoo.
Gray hair cover.
Not just gray hair cover. Shampoo too. Gray hair
Just
shampoo.
remember like the stuff that you
Yes,
the gray
right.
hair cover,
Yeah.
hair dye thing.
Weight gain, muscle wasting, fatigue. So you see a lot of the same symptoms. Cholesterol issues. So many times I see people with cholesterol issues get put on a statin. Nobody's even investigating why the cholesterol might be an issue, and it's even in people who are active and they are eating well, their cholesterol is high. It's just, here's a statin. We don't care why it's high. Well, if it's high and your hormones are out of whack, the statin's going to do absolutely nothing.
Yeah.
It might drop your cholesterol half a point. Okay, so, and then there's also a lot of hypothyroid symptoms in here too. So weight gain, insulin resistance, fatigue, depression, anxiety. And so there's a lot. Preventing skin from sagging, body fat, bone strength. Elevates norepinephrine in the brain to make you feel alert and awake. Most of you falling asleep over here.
Well, I have some of that testosterone.
Boring. These are the main neurotransmitters, mainly because they're kind of some of the first ones we discovered, and they're most abundant for the most part in the brain. GABA, glutamate being most abundant. GABA is actually the brake pedal of the brain. It's what makes sure that the brain's not overfiring. And then just for make a point, see the symptoms? Low or high of those can cause all those symptoms. So again, this is something you can't just guess at, right? And for the most part, when we see people with anxiety, panic, sleep issues, we immediately jump to the serotonin drugs. And then when those don't work, we might bring in a dopamine-related drug like Wellbutrin, and then we kind of throw our hands in the air and go, I don't know. There's all these other issues, and really those drugs just trick the brain into thinking it has more than it actually does. It doesn't actually balance out the effects. So they're great to do because you need to balance your brain out while you work these issues out, because they can take some time. But this is a good diagram for people. Actually, you also put in the wonder list for me to print off and laminate some sheets for these guys to have in their office to show people examples. This is one of them. Right? These are all the different areas in the brain that estrogen is required to stimulate. So there's ER beta. GPER is a G protein receptor. So it actually is, when estrogen triggers a receptor, it actually causes the DNA transcription to change. So our gene expression changes, something called epigenetics, which being talked a lot more about lately. And so you'll see in the blue all the different symptoms and issues that can arise from those areas not being stimulated properly. Communication issues, this is largely studied. fMRI studies and other neuroimaging techniques, diffusion tensor imaging, PET scans even showing multiple subconcussive blows causing structural and functional integrity issues. And these are, again, I wasn't ever diagnosed with a concussion, but I've been hit in the head a lot type thing. So they can cause a lot of issues. The uppers, this just kind of illustrates what happens here in the upper cervical for the front to back injury. Again, you're getting the coup counter coup with the brain hitting the forehead and then the back of the head, depending on the direction. And then if you do a top to bottom scan of the upper cervical, you see this guy here. That's the U shape. It looks like a mouth guard, kind of, with two little sides off on it. That is the atlas. So it's our C1, and then the axis sits underneath of it and comes up through kind of like this little piece actually comes up and around. And the relationship between those two, you can see over here with just a 6-degree rotation, these dentate ligaments, which are these four lines here,
gosh.
they get pulled in a certain direction, and all of a sudden now you're having the spinal column actually contacting the spinal cord, which the reason we have cerebral spinal fluid is to prevent that, because it'll cause misfiring. I've seen people have extreme cases of rheumatoid arthritis from this, where they're getting autoimmunity triggered. And yeah, that's, I mean, just a 3-degree axis and a 6-degree atlas. And if they turn opposite ways, it's even worse. So these ones happen to be kind of rotating the same way, but there's oftentimes people actually have it the opposite way. And usually that's from hits to the top of the head that compress the spinal column. This is usually what we see in the Loretta, where that you can zoom through, that gives you the MRI-like images. So there's lots of different techniques. If there's been ligament damage, prolotherapy is really useful to tighten it up. Oftentimes people have muscle tightness, like their neck and shoulders are always tight because it's trying to compensate and hold everything in place. Yes. Brain spotting and relaxation, EMDR, if there's trauma that's causing the tightening of the motor cortex. NUCA is the most traditional or the most conventional technique to just kind of like, they just want to try to push it back into place. But for some people, they don't hold it if there's these other issues below. TRT, torque release technique. This is the main thing that Dr. Jeff in Kelowna does, and it's also quite useful. Excuse me. You guys know neurofeedback. You're picking up real-time info, and you're feeding it audio-visual, and then the brain picks up whether it needs to elicit more of that behavior or whether it needs to change itself. And because the brain loves stimulus, as soon as it doesn't get any stimulus, it gets upset and it'll change itself in order to obtain more. And so we just kind of play on that principle and variable to try to guide it back into a better. Really get the trauma communication. If there is stress and limbic issues, it will also help balance hormones. We had one guy who I said about this completely the wrong way, and he assumed that he went to the doctor and get his hormones and his testosterone was raised, that even was actually not replacement right away, and I had said that it would drop his test, that neurofeedback could do. Neurofeedback does not. The only thing neurofeedback will do is calm cortisol reaction. So if cortisol is high, it can help bring that down because of relaxation and the limbic system not reacting around it. So really, your only effect you're going to have on testosterone and estrogen and your other hormones is going to be they're going to go up, right? Because you're not getting the pregnenolone and steal cortisol. So if anybody ever asks or gets confused about that, that's why I've been trying to get hold of Christian for that. So yeah, so cortisol network issues.
I completely misinterpreted what Corey had said, and I questioned Devin. Yeah.
I don't know. So his doctor told him to stop neurofeedback immediately, and now his doctor wants reports from us. And like these guys, they talk like neurofeedback's placebo and doesn't work. Yet then they do that. They say, well, it's all neurofeedback that did this to you.
So you said it didn't work.
Yeah, no, that's your reports, right? So they
like he's gonna make sense of your reports anyway.
Yeah. So this is a lot of gibberish. This is intense neuroanatomy, but we have these different divisions. So you have hypothalamus, hippocampus, pituitary, amygdala, and then you have different divisions within those little tiny organelles. So it makes everything complicated. So that's like if you see central nucleus of the amygdala, there's all these different nuclei in the amygdala. Same thing with the hypothalamus. There's a paraventricular, lateral. There's a whole bunch of different types. But when we utilize biofeedback, and this is one of the reasons we do the breathing initially, we actually consciously access our insula and our prefrontal cortex to the best that we can if we're not having limbic inflammation. And those actually have direct innervations onto these areas, which actually affect something called the periaqueductal gray, which Bessel van der Kolk calls the cockroach brain. The cockroach brain. So the cockroach brain is just a really reactive part of the brain. It's what's present in insects. And so we still have that.
Survive or die.
And then it depends. And now this has been reinstated since Stephen Porges proved the polyvagal theory. But initially it's either rostral ventrolateral medulla, and that goes down the spinal column and can trigger a fight or flight state or calm a fight or flight state. The dorsal vagal will trigger a faint or freeze state. And so we can actually, by doing biofeedback, balance this whole system out and trigger more of a rest digest, which is a ventral vagal. And these are just some diagrams of, four session change. Yeah, so you want to see all those lines go down as low as possible.
Yeah.
And those are the maps that show the change. So we have all sorts of data. If you guys ever need any pre-post data on anything, we pretty much have it. So more pre-post. So you're getting, and this, a lot of this is actually just neurofeedback too. In some cases, people do really well. And then just to fire it off, ounce of prevention is worth a pound of cure. And this is a field I want to eventually get into. It's a hard sell right now because when people don't feel bad, they don't value their health, right? Athletes a bit more than a lot of the normal population, but even they if they're feeling good, they're feeling good. And a lot, like what I want to teach about head injury is that stress tank that already has stressors in it, because we all have them, can be reduced so that people are less likely to get this whole cascade. Because once like Pandora's box, right? You can't put Pandora back in the box.
But
So-
you gotta look.
So that's huge, even for head injury. And people kind of look at me a little weird when I say that, but it's true. There's lots of research that shows preventative, even just looking at nutrition can be huge.
Yeah.
Initial concussion treatment. So treating concussion directly usually is only effective in the first 3 months. So hyperbaric oxygen is a really good one if people just have a head injury. There's a period where they have to wait for the acute stuff to go down, and then they can get in hyperbaric, and it can be really helpful. But if they start doing it after the first 3 months, usually what ends up happening is they get a little better while they're doing it. As soon as they stop doing it, everything starts trickling back, which just means you're missing something, right?
Mhm.
So that's where we specialize, is after the first 3 months. So if anyone asks you about an acute injury, it's good for them to come in and get a baseline, but then they need to take some time to recover and then come back in 3 months and do things like, we of course would get them on neuroprotection and that sort of thing, but come back in 3 months, train the brain and all the communication issues that would have happened from that. And if any of that above fails, you have to look at downstream effects. So you start looking indirectly. You don't start targeting the head injury directly anymore, because it's going to be useless. People are just going to waste their money.
Yeah, and so just to reiterate, we don't need to send them away and have them come back in 3 months down the road. We can do things in those first 3 months still.
Suggest supplements.
Yeah, nutrition, supplements, lifestyle.
And then and again, most people aren't going to come to us anyway unless they have severe symptoms, unfortunately.
Nothing else would help.
Post anyway.
Yeah.
So
And the unfortunate part is things turn on, and it could be a decade later when all of a sudden everyone comes back.
Yeah.
So it is important to get looked at the very least and assessed. And everybody's different, and everyone requires a different approach. And there's all of these different things affect our ability to big things, test, don't guess, look, don't assume. And if I see this happen all the time too, is doctors are notorious for it, and not all doctors, but they assume. And that's not good science. They're literally supposed to be scientists.
Non-science. Yeah. Assumptions are